We like the day before surgery with our co-workers and residents to draw the surgical target according to the patient features. And we like to draw a drawing of the lesion we will see under surgery. And this favorizes training, and we can define on the planning the respective role of the collaborators, including the residents, so they can be involved more actively in surgery under control. And this is pre and post skull base cavernous sinus meningioma. Another tips is to stress on ergonomy and sobriety, that rather than sophistication and plethora of instruments. We have to negotiate installation with the anesthesiologist, think about comfort, not to be tired, and use few but appropriate instruments. We don't need a plethora of instruments. And I stress on good bipolar coagulation forceps, regulated aspiration. What about intraoperative neurophysiology? If we estimate it's useful, we have to put that under regular practice, but take care. We must keep autonomy from too sophisticated clinical neurophysiologists. We have to distinguish detection, mapping and monitoring function, and call it intraoperative neurophysiology, and not put under intraoperative monitoring all these components. I insist on debriefing after surgery. This debriefing should be critical, but should stay fair. And we have to differentiate the error in indication and the technical mistakes. What about tricks? I take the example of meningioma. I was surprised when I came into the field that the so-called benign, treatable meningioma had sometimes a difficult outcome with infarction outside the bed of the lesions. So we have to think about why. If we consider even convexity meningioma, consider easy to remove. If you do selective angiography, DCA, we can see that there is part of the vascularization coming from the dural vessels and also a part coming from the pyocortical vessels. And this cannot be strictly cleavable because pyovasculature, when we remove the tumor extracapsularly, we avulse pia mater, and this is a cause of so-called infarction. And we must take into account selective vascularization of the meningioma and pre-program surgery according to that. And this is logical because meningioma do not come from dura, they come from arachnoid, and arachnoid has two vascularization, external and internal. This can be predicted by CT scan and MRI. As a matter of fact, we studied that and published in GNS a long time ago. Hypodensity, peritumoral, means corticopial implication of vessels in vascularization. And we can predict outcome according to that. Now, we after considering arterial vascularization of meningioma, we were interested in venous implication in meningioma surgery, and especially how to remove and to protect or to reconstruct vein in so-called venous implication of sinus invasion. This is our series, and the result of our series. By attempting a total removal, we had 4 recurrences out of 100 patients. So we think that it is a good way to start for a radical. And what about venous reconstruction? You can see that the 3 patients who died were patients in whom we did global resection of invaded portion of sinus without reconstruction. So this incites us to reconstruct veins. For reconstructing veins, we use semi-sitting position to decrease the intracranial pressure and the venous sector. Scalp and bone slice slightly too large to control both sides of the meningioma in the sagittal region, and bone flap and opening of the dura both sides. We must take care during the approach that there are collateral venous channel going through the bone, the dura, the bone, and under the skin, and we have to take care with that. What about to control the sinus? We don't use aneurysm clip, we don't use balloon, we use platelet of Surgicel, and this makes surgery rather easy. But because there is risk of brain swelling, we must be prepared to stop at any time if brain swelling threatens. We classify the meningioma in 4 types, and this condition the surgery: type 1, 2, 3, 4, 5, 6. And we published that in GNS in 2006. What about type 1 and type 2 of meningioma? Type 1, only peeling of external lesion. Type 2, simple resection of invaded recess with resuturing. Type 3, resection of invading walls. And type 4, same, with patch reconstruction. This is not so difficult to master that if we have prepared the surgery for that. An example of 4 type, type 4, and before and after surgery, you see the patent circulation of the venous in the mid-third. Type 5 is total occlusion, but one wall is preserved, and we can obliterate the sinus by Surgicel and remove the tumor inside the lumen. We did that in 2 patients with a torcular meningioma with a complete obliteration on one side, subtotal on the other side, and we could extract and reconstruct by patch, as you see on the control. This is risky operation, but we are lucky and a good outcome of that. Type 6 is total invasion with all 3 walls invaded. So we start from a complete resection and with a bypass reconstruction. Bypass reconstruction with the sector is short with the external jugular vein, you can see this case, or this other case, excuse me, torcular occlusion, we stay with the fragment remaining in place and put a bypass cervical because the patient has a huge intracranial hypertension. We can also, I would say it's a kind of play to reconstruct the veins, especially in middle third, like in this patient. What about angiographic control? We can see that all patients who had prostheses with Gore-Tex occluded postoperatively, so we must use harvested vessels, harvested fascial temporalis. Important is to start anticoagulants as soon as the day 0 and as long as 3 months with antiaggregants until re-endothelialization. And thanks to that, our patency rate was not too bad, and we had no hemorrhagic complication by doing that. In conclusion, don't be afraid with the venous reconstruction. Act very careful with the afferent veins, and perhaps we must not be so ambitious, and thanks to radiosurgery at present time. If we have time, we have 5 minutes on that. I took care with the superficial cerebral hemispheric vein and danger during approaches, and in the interhemispheric approach, there is a risk with the afferent vein of the mid-third. In the perineal approach, there is a risk with the anterior Sylvan vein, especially when there is a major draining to the cavernous sinus, and we must take care with the inferior cerebral vein in the subtemporal approach, and we call this the Labbe vein, drama vein. If we interrupt this vein, we can have infarct And like in this patient, we had a sequela with us with encephalomalacia due to venous infarction. This is well known from all neurosurgeons. From one patient to another, there is variation in the venous predominance of the hemispheric drainage. In first patient upward, this is an anterior sylvian drainage predominant. In the middle, superior venous predominance with the trolar vein, and in the inferior picture, inferior drainage predominant with the Labe vein. So to know that and to take into account, with imagine topogram published in World Neurosurgery in 2020, we define 3 triangles for skull-base approach with a phlebogram. Anterior triangle, where are located the frontal veins and danger in the anterior approach of skull base. Middle triangle, where the anterior cerebral vein, when predominant, is in danger, and posterior triangle, where the inferior cerebral veins are in danger. And to construct this triangle, this is rather easy. The point is interventricular venous confluence, and this is the Galen vein, the basilar vein of Rosenthal, the thalamus, the internal cerebral vein, formed by the septal vein, the anterior caudate, the posterior caudate, and the venous thalamus striate. And the confluence is there. It is a fixed landmark at the foramen of Monroe. And starting from there, we can draw the 3 triangles I show you in the previous picture. And what about my recommendation? Of course, we have to work. Work is the main power to succeed with the patient. But to improve, we have to learn and learn all the life from best experts and take their message to you. To be creative, we have to valorize cross-fertilization, especially with physiologists. We have a lot of things they know we can apply to surgery and improve. And of course, engineer for technology. Learning and teaching at the same time, jointly all the life, not only when we are training, helps. Both are wonderful friends, and we have to act as a member and at the same time booster with the team spirit. Surgery is a teamwork. So thank you for attention. Thank you for attention.
Well, thank you very much indeed, Prof. Sindou, for managing to distill an entire career of 40 years into half an hour, and for giving us so many tips. I liked particularly avoiding narcissism, acrobatics, and snobbishness. And so much ego is invested in neurosurgery. And you're saying craniotomy of the appropriate size, not the smallest craniotomy you can possibly make, because the patient can't see it. They don't know how clever you are. That's absolutely wonderful. Thank you very much. I'll hand over to my 2 discussants, Vikrant and Yusuf.
Good evening, Professor Sindhu and all guests here. And it was a wonderful presentation, especially the approaches, the role of sinuses and the afferent veins and how to repair them. The approaches to repair them, especially when the tumor is invading the lateral wall of the sinuses, you have to take care of the repairing these sinuses. But one thing, Professor, I would like to ask, in these areas, in the mid sinuses, mid 1/3 of the sinuses or posterior third of the sinus, if at all the afferent veins are draining into the sinuses and the wall is being invaded by the tumor, what you would like to go for?
The main problem, as you said, is middle third. There are many precentral and postcentral veins, and this is very dangerous to work there. If the invasion of the sinus in the mid third is very limited, we can extract and reconstruct. If it is extended, we may be better to avoid some acrobatic surgery in the mid third. Surgery in the sinus is appropriate for the posterior third, but because there are not many afferents in the posterior third. So take care in the mid third with afferent veins. In the posterior third, almost no afferent veins.
Yes, I do agree with that.
Maybe
Well,
at the present time, we must be more prudent because we have the stereotactic radiosurgery. When I launched that, radiosurgery was not so popular at that time for that.
Yusuf, do you have any comments or questions?
Yes, I mean, this was an excellent talk, and I do have a question though. I mean, when the professor mentioned about reconstructing the sinus and the use of anticoagulation, have you noticed that the use of anticoagulation post-op, does it increase the risk of post-op hematoma formation in the tumor bed, or do you had a case where the patient developed a bleed following anticoagulation?
The early morning after surgery, next day, early morning after surgery, we always ask for a CT. And if the CT was okay, we started a very early next day anticoagulation with heparins line for 2 weeks. And then we moved to antiaggregants. I never had hemorrhage due to anticoagulants.
Okay.
This is
Okay,
well
another-
controlled by specialists in coagulation and by intensive care unit people.
Okay. And one more thing I wanted to ask is that we have a lot of young neurosurgeons here. So if there is, if we have a young patient who's 35 years old and have a meningioma that is invading the middle sinus, so what do you suggest? I mean, should we actually plan and go about removing the tumor completely, or it is wise to leave some part of it and maybe use and some other sorts of it's like stereotactic radiosurgery or something for the residual tumor? What's your take on it?
I'm afraid I did not understand all your comments and question. My English is not that good. When I was young resident, I saw so many problems with the veins or incomplete surgery on one side and the management of vein on the other side. So I decided to go in the laboratory to work in animals, mainly dogs on veins. And then I tried to apply bypass I organize in animals to patients. And I must say that I decided for most of the patients to be as radical as possible and to repair the vein as much as possible. And I saw results. We were not the best of the literature. On the contrary, I must say, one of the best. So they insisted me to be aggressive. I insist again that in the mid-third, we must take care with the veins. You know that very well. But I am rather enthusiastic about starting for radical and repairing vein in the especially posterior third, even torcular. And at present time, because stereotactic radiosurgery is there, you mentioned that, I think that I don't incite to be too excessive, you know. So this is a long surgery. And more and more, we cannot afford long surgery because economic problems in the hospital or in private institutions. So this is a limitation. So I encourage to do that, but be prudent.
If I could ask a question, Prof. You talked about the type 6 tumors when the whole sinus is involved. But very often, the sinus is pretty much obliterated. So you've got sinus at the front, sinus at the back. Would you not, given that it's been occluded for probably a long time, is it not simply reasonable to excise the tumor and not try to reconstruct the sinus?
Very good question. When we approach the type 6, we destroy many vicariances at periosteum level, bone level, dural level. So it might be useful to put a bypass. Bypass can be short with the external jugular vein, which has no valvula, when the resection is short, less than 10 centimeters. And when it is longer, we can use internal saphenous vein, which is not so propitious for patency. The 3 patients who died in my series, this was published in GNS, were patients in whom type 6 was totally resected without reconstruction because of delayed swelling. So theoretically, we can remove without reconstruction, but if we can if we see some swelling appearing, I recommend to do a bypass, total resection and bypass.
Do you think that problem was due to some of the collateral veins actually being involved in your resection? So
Yes.
you didn't simply remove the occluded
Yes.
bit, you were
I
actually...
saw brain swelling before starting removal of the tumor because destruction of all the collateral pathways. I saw that. We must be prepared to stop and to delay the second step, resection and repair, if we see brain swelling occurring, or on the contrary, we can go ahead and do the reconstruction. I'm not so sure of my opinion on that. This is critical and challenging, and we can discuss that.
Well, bad experiences always form your policies, don't they, along into the future. If neither of the other discussants has any burning questions, is there anybody else online who'd like to ask a question?
I have, Alistair. Dear Professor Sindou.
Yes.
Actually, everybody knows you for you have done great works on DRES lesions. And then after came some stimulation techniques, even spinal cord stimulation, deep brain stimulation, some others are coming. Do you think the value of DRES lesions have decreased or not?
Very good question. The problem of indication. If we take the example of brachial plexus avulsion, in my experience, spinal cord stimulation does not work. We have done because there is no more fibers from the dorsal root ganglion up to the brainstem for avulsion, precentral lesion. Second, for pain, in the segmental pain after conus medullaris injury, spinal cord stimulation does not work. Deep brain stimulation does not work. So these are main remaining indication of dorsal root entry zone lesioning, whatever the modality of lesioning be. So there are very good indication. First, avulsion of roots. Second, segmental pain after complete crushing of the spinal cord, especially in conus medullaris. And we can add some cancer pain, limited cancer, for instance, the thoracic apex, with long survival time of this patient. And there are remaining indications. Besides neuromodulation, we have done a lot. Besides deep brain stimulation, we have done a lot. Besides intrathecal pharmacotherapy, we have did a lot.
Do you have any experience of the newer high-frequency spinal cord stimulation? Because I have to admit, I have not done a DRES lesion since high-frequency 10,000 hertz came in, because it seems to work in a totally different mechanism. It seems to act on the spinal cord itself. And for the cases that you mentioned, you can put it right up almost to the foramen magnum. And I don't know whether you feel... I think Mehmet's maybe hinting at the same thing, that maybe DRES is on its way out. And it's a terrible thing to say to you, of course.
Okay. I have no experience. I have some experience, but not enough experience about high frequency spinal cord stimulation. So perhaps this will reduce the indication of DRESS lesioning for avulsion. Yeah, this is a new coming method. Apparently you have experience.
Yeah, I've done a lot, and it's interesting. We've actually revisited some of the patients who we had rejected with just for a conventional spinal cord stimulation, or who'd had it and failed, and they are now successfully treated with high frequency. That's for another day.
I think you are probably right.
Yeah.
I believe you first, according to your experience, and probably you are right for the future. Avulsion means no more dorsal column fibers to stimulate. The tonic stimulation cannot work. We have experience on that, of those failures. And we are recording with microelectrodes the dorsal horn. There are hyperactivity in the neuron of the dorsal horn after avulsion. And this is the target of the DRESS lesioning. And probably high frequency can, to say that, opposed to this hyperactivity.
Yeah, that may be. Any other questions from anybody online? Please just unmute yourself and shout out if you have, because there's too many people to see hands raised. No? And from the two discussants, Joseph and Vikrant? It just remains for me, I'll hand over to Mehmet, but I just want to thank you very much indeed, Prof. Sindou. That was absolutely fascinating to hear about your career and about your tips and tricks. And I think this is an excellent series, and you have been a fantastic contributor. So thank you very much indeed. Mehmet, would you like to close?
Yeah.
So thank you to you, Alistair. Thank you very much. Thank you to Mehmet. And the future is a young generation.
It was a
As
great
always.
honor for us to be with you and listen your tricks. Really, I thank Alistair and all two discussers together with Professor Marc Sindou. Thanks, Professor. Goodbye.
Thank you very much.
Thank you very much. Thank you.
Bye-bye, everybody.
Goodbye.
Thanks again.
Goodbye.
Thank you.